Hello everyone, this is I will teach you medicine, and we are discussing congenital cataract. And in the last video we have discussed all the types of cataract and the definitions and all the mnemonics, and morphology. So watch the previous video if you haven't. So without any further ado, let's start from the point where we left. So we were at the symptoms of the developmental cataract. So in the congenital or developmental cataract, the informant is usually the parents, and the history of the they give the history of like a white spot in the pupillary area, leukocoria. And child is usually brought with the history of diminution of vision, which does not diminution of vision or does not recognize objects and parents, diminution of vision. So uh, that will lead to not recognition of any object or parents, and the parents also inform them about the history of the unsteady eye and deviation of one eye. It is due to the strabismus. We will know about it in the topic amblyopia and strabismus. So yeah, so any associated symptoms of any systemic disease if present, and signs. Okay, the signs are very important because here we can find out the diminution of diminished vision. At times it is difficult to establish in a very young children, because we cannot the children are usually they are small and they can't respond properly if they are seeing properly or not. So diminished vision, there are very different techniques which we use for any kind of visual examination in children. I think I will make another video about it, but let's just focus on it. Okay, science includes the diminished vision, and there is a lenticular opacity, and in some children nystagmus is also present, and there is deviation of eye, and there may be other ocular and systemic abnormalities in case of rubella nuclear cataract. Okay, and that varies according to it. So what are the differential diagnosis? If a child has history of white spot, and then diminution of vision and not recognizing parents and objects, and unsteady nystagmus eye, deviation eyes, and the lenticular same thing. So what are the differential diagnosis of a child? So that can be or we can just say what is the differential diagnosis of congenital cataract. That includes retinoblastoma, toxoplasmosis, toxocariasis, retinal detachment, retinitis of prematurity. This is also known as ROP. And this is the another one is persistent hyperplastic primary vitreous, PHVV. ROP, PHPV, Coats disease, coloboma. We will read this under the topic leukocoria. So just learn these names: Coats disease, coloboma, myelinated nerve fibers, retinal dysplasia, Nouri's disease, and incontinentia pigment. I don't know what is this. All right, I don't know what's this, so find out about that. Retinoskis and cyclitic membrane. Okay, these are just very fancy names for MBBS level. Retinoblastoma, toxoplasmosis, toxocariasis, retinal detachment, ROP, PHPV, Coats disease, coloboma, retinal dysplasia, and then yeah, I think that's coloboma also. Yeah, that's, I think that's enough. So now let's go to the management. So diagnosis, management, how will you manage? So it will start from the history. All right, so let's start with the history, like duration from when the symptoms has like seen, and any familial history of congenital cataract. If there is any kind of family, or their children's the child's any brother or sister, or their parents or their grandparents, even their grandparents, whether they had any kind of congenital cataract or not. So visual status means ambulation in familiar and in unfamiliar surroundings. Visual status, how is the child's visual status. And there is a behavioral pattern and school performance. How is child in school, because of all this sign, diminished vision, and then deviation of eye, nystagmus, and opacity, unsteady of eye, that it can it can be seen on the child's school activity, his behavioral pattern. So we also have to know about the history, little bit more on this, on psychological aspect, I would say. So birth history. like history and degree of consanguinity, consanguinity. History is also very important. And then history of maternal infection during the first trimester, or as we discussed earlier, second month, any kind of infection. And then whether the child was gestational, what was the age when the child was born, gestational age, and the birth weight, because like underdeveloped child has increased risk of developing the developmental or congenital cataract, and traumatic history of any kind of birth trauma. And then supplemental O2 therapy in the perinatal period, because this is also very important in the same developmental aspect. And then developmental milestone, whether the child has any kind, like he's a normal child with all the developmental milestone, or he's lagging behind. So that is also very important. So in the diagnosis, so that was the history part. So in the diagnosis, we have to conduct an ocular examination. So measurement of the visual acuity and up-to-date refraction should be available as part of the optometrist report. So when you enter the OPD, there should be like optometrist will perform the measurement of the visual acuity. So yeah, we have this same thing. Okay, let's first discuss this then. And then pupil examination, and then external eye examination, including the lids and the lashes. And then measurement of the IOP, intraocular pressure, should also be like measured. Slit lamp examination, because it is like associated with congenital elements of the iris and the lens. And then we will have also find about any kind of cataract, like type of the cataract you can see. And we will see the iridodonosis and phacodonosis. Iridodonosis is like a iris, like this is the eye and this is iris, right? So as the patient moves their eye, the iris muscle will also shake accordingly. That is known as the iridodonosis. So slit and examination will give us idea about three types of thing. That is whether there is any congenital associated congenital anomalies of either iris or lens, and it tells us what type of cataract it is, and whether there is presence of iridodonosis or phacodonosis. And after that slit line examination, we have to do the dilated examination of the cataract and the fundus, and biometry if the child is old enough to cooperate. Okay, this may do not if not, this may be done under the anesthesia. If the child is uncooperative or too young, then we can do with under anesthesia. So let's discuss again ocular examination. Since a formal estimate of the visual acuity cannot be obtained from the neonates, following in the neonate case, like formal estimate, you can't exactly say that the visual acuity of this child is like XYZ. No, you can't. So following should be carried out in order to assess the visual significance of the opacity. It is also important to examine the parent and the sibling. So density and potential impact on the vision, assessed on the basis of appearance of the red reflex and the quality of the fundus view on the direct and indirect ophthalmoscopy. We have to do that, like potential impact on the like visual function. So we have to like check, assess on the basis of the appearance of the red reflex, whether the red reflex is present or not, and what is the fundoscopic view of the fundoscopic view by direct or indirect ophthalmoscopy. And then the morphology of the opacity, what is how is the opacity like placed, like here it is central or peripheral, like that. So it can gives us the clue about the etiology. And then associated ocular pathology, so in anterior segment it may involve corneal clouding, microphthalmos, small eyes, glaucoma, persistent fetal vasculature, any kind of fetal vasculature like hyaloid artery, like we studied in the last video, that can also be associated. And in the posterior segment, chorioretinitis, uh, leberomorphosis, I have no idea what this is, rubella retinopathy, foveal or optic nerve hypoplasia. So it can be associated with chorioretinitis, chorion and the retina, they are both inflamed, and rubella retinopathy, and then foveal or the optic nerve hypoplasia. So that can also be associated in ocular pathology. And other indicators of the severe visual indicators, absence of the central fixation, means the child can't fixate his eye on centrally, and nystagmus, and severe visual impairment, we can say nystagmus and strabismus. So that is the like ocular examination. So now we have to move on to the systemic examination. So unless there are established hereditary basis for the cataract, the investigation of the infant with the bilateral cataract should include the following: bilateral, if the patient has like investigation of the cataract, unless there is an established hereditary basis. So we have to conduct the following tests. That includes torch test, toxoplasmosis, rubella, cytomegalo, herpes virus. Torch serology should be done. Another is used for urine test, that is for galactosemia. It is a condition in which there is the we can find in the urine we can find about the if the baby has galactosemia or not. mm, and then chromatography if Loeys syndrome is suspected. So let's discuss a little bit about galactosemia. So here what this a quick Google search says that it is a deficiency caused by any three possible enzymes in the which is responsible for the metabolism of the galactose. That include galactokinase, transferase, or epimerase. So any kind of reduction in these enzymes can lead to the cataract. So how does it does it can result in cataract through the accumulation of galactosol in the lens. So the lens has all this due to this impairment, biochemical impairment. All the galactosol they deposit here, accumulate, so they also produces cataract, eventually cataract. All right. So it is galactose 1 phosphate uridyl transferase deficiency. Galactose 1 phosphate uridyl transferase deficiency is the exact enzyme name. And then other symptoms also can persist, like failure to thrive and diarrhea, jaundice, hepatosplenomegaly also occurs, and cataract due to galactosol accumulation in the lens. So, in the Loeys syndrome, it is also known as oculocerebrorenal syndrome, because it will affect the eye, cerebral cortex, and the renal kidneys. So it is also known as the Loeys syndrome. It is a X-linked recessive disorder. Characterized its feature include congenital cataract, 1 number, 2 number is hypotonia, 3 number is intellectual disability, and the fourth number is the proximal tubular acidosis and amino aciduria, that is presence of amino acid in the urine, and low molecular weight proteinuria. This is all in the renal part. So low proteinuria is also occurs. So in we do this test for the diagnosis, we do the chromatography for amino acid. So we will take a jar, and then we will ask the baby to fill the urine here, and if he has a Loeys syndrome, then this will contain, the urine of the child will contain amino acids, all these amino acids. So we will do a filter paper for chromatography test, and it will suggest positive. So we can also associate it with the Loeys syndrome. So it's very simple. And now blood test for hyperglycemia, fasting blood glucose of the child, and then serum calcium and the phosphorus for x-ray skull for hypocalcemia, any kind of metabolical imbalance. That is if there is hyperglycemia in the child or hypoglycemia, so hypocalcemia. So if the calcium in the body is low, then the parathyroid hormone will increase. Parathyroid hormone will cause the breakdown of the calcium from the bones. So we can see the x-ray of the bones, it will cause the thinning of the bones. So we ordered the x-ray of the skull. And then red blood cell transferase and galactokinase level, again for the galactosemia. And then referral to the pediatrician. So we have to refer to a pediatrician, because any kind of the dysmorphic fiction, the patient, all the child can present with failure to thrive, and other any many kinds of the pediatric diseases and symptoms. So we have to refer for not only for eye, but also for other systemic management. All right. So, and chromosome analysis may also be useful. So we have to refer to the pediatrician. So in the systemic management, we have to do the torch test, urine analysis for galactosemia, and the Loeys syndrome. For Loeys syndrome, we have to do chromatography for amino acid test, and blood test for any kind of metabolic disorders, hyperglycemia, hypocalcemia, and then transferase level, RBC, and the galactokinase level. And then we have to refer to a pediatrician. So we can see already here. Diagnostic evaluation for galactosemia, urine reducing substances, laboratory test, we do that. For rubella, antibody titers, antibodies against rubella, we can see that. And then syphilis is for VDRL test, congenital syphilis. Hypoparathyroidism, we can see the serum calcium, phosphate, alkaline phosphate, and also X-ray of bone. And Wilson's disease, it can be done with the investigation of by checking the serum ceruloplasmin. And then hyperglycemia or hypoglycemia, we can do by the fasting blood glucose. Fabry's disease, it is also we have to see any kind of the Maltese crossed, in polarized light. If, we have to check the urine. And Loeys syndrome, by chromatography, we have to check for the urine amino acids. So what is the management? How do we manage? Like, what do we suggest? Management includes all history and then investigations, so also includes the treatment, that is how we will get this child to feel better. So indication and timing of the pediatric cataract surgery, that includes here's one simple table, so we will get that later, we will get to that. So indication for the surgery, they are interfering if the disease, that is cataract in this case, is interfering with the quality of life. Yes, of course, if the visual acuity is less, then it is affecting the quality of life, because the child cannot perform well in the school and then also in the home, and he will have some kind of anxiety, as he will grow up. So that it is an indication, absolute indication. And then there is a reasonable prospect that surgery will lead to the significant improvement in the vision. So yes, of course, any kind of the cataract surgery done in the pediatric group will improve. If we have the hope that it will improve, then we have to do the surgery. And all dense cataract and the partial cataract, any all the dense cataract, the density is more, and it has to be done. Either it is unilateral or bilateral. And in the cases of the partial cataract, if the vision is only less than 6 by 18, if the 6 by 18 or less, then the children should be done. Otherwise, if it is manageable, it's either more than this, then it can be symptomatic management can also be done. But it is indicated if the vision is less than 6 by 18. So timing, the critical period of development for reflex, is between the 6 weeks and 6 months of age for the development of the fixation reflex. So the best timing of the surgery before this period, for the prevention of the stimulus deprived amblyopia. So why we do before the period of the 6 weeks to 6 months? Because the critical period for development of fixation reflex, the child can focus on one point, that the critical period for development is at the 6 weeks. So best timing is before this, because after the child has developed the fixation reflex, then he can develop due to he can develop stimulation deprivation amblyopia, and yeah, due to opacity in the cataract. So it should be done before 6 week. And then in dense monocular cataract, the surgery should be done as early as possible, maybe on the next day after the birth. So second day on the birth, the monocular cataract should be done if it is dense. So unilateral dense cataract is urgent surgery is advised within, if it is unilaterally both eyes, if there is unilateral and there is a dense cataract, then within days it should be done. Very aggressive anti-amblyopia therapy, okay. And also aggressive anti-amblyopia therapy. There are other therapies to prevent amblyopia in a child, so it should be done. And results are often poor in unilateral dense cataract, so we have to consult the parents already as well. And if detectable after 16th week of age, then the surgery is inadvisable, because amblyopia is refractory. Because if the 16 weeks, if the patient with a unilateral dense cataract has if the cataract is detected after 16 weeks of age, then the amblyopia will be refractory, so it is surgery is inadvisable. And partial unilateral cataract, it can be treated non-surgically. So here's one simple table. what we can do is timing of the surgery, if either it is bilateral or unilateral. So in bilateral, if it is dense and partial, and in unilateral, dense or partial. So dense is, it is an early surgery, that is 4 to 6 week of age, before 6 weeks, to prevent the development of the stimulus deprived embryo. In the asymmetrical, if there is like bilaterally dense, you heard this eye is also by both the eyes are have opacity, and then like which surgery we should do first, if there is like asymmetrical severity, if this is more and this has the less severity, so we should do the surgery of first of the denser cataract should be addressed first, we should address that one. And in the bilateral partial, we have to like defer surgery, monitor lens opacities, visual function, and intervene in the lateral vision, may not require surgery if it is bilateral but partial. So it can, we have to we have to intervene the visual function and opacities, but surgery may not be advisable. So in unilateral dense, it has to be done very urgently, is within, if the child is born today, then we have to do tomorrow, like day one is he's born, and then day two, if the child has unilateral dense cataract, then we have to do it urgently. So and then follow up aggressive, yeah, and then that is that. And cataract is detected at after the age of 16 years of age. The surgery is inadvisable due to the that amblyopia, that is refractory amblyopia. And unilateral partial, that we don't have to like do surgery, but we have to like do like treat it non-surgically with pupillary dilation and part-time contralateral occlusion. We have to occlude like both the eyes, so we have to occlude some eye one time for 2-3 hours, and then to the other you have to partially occlude. And then let's move on to the cataract surgery. What are the surgeries we can do? And then yeah, so there are the three major surgeries, that is lens aspiration with anterior vitrectomy, and lensectomy. So this is very important. So is let's not get more detail into it, but lens aspiration we can do is we can implant the intraocular lens in the bag and maneuver the with the poorly dilated pupil. This is just watch some videos in the YouTube or somewhere, and then it can cause the risks of endothelium loss and astigmatism. It can like increase the chances. So it is the preferred method when intraocular lens is implanted in a child. And the next technique is the lens aspiration with anterior vitrectomy. So it will reduces the chance of the posterior capsular opacification, because we are doing the anterior vitrectomy as well. And has the disadvantages, it increases the risks of the cystoid macular edema. So it is a preferred method in a child less than 2 years of age. So lens aspiration with anterior vitrectomy is preferred in the children with less than 2 years of age, whereas the lens aspiration is preferred method where intraocular lens has to be implanted. And then next one is lensectomy, that means lensectomy means removal of the lens. So no posterior capsular opacification, it will reduce the chance. Lens aspiration with anterior vitrectomy will reduce the chances, whereas the lensectomy will completely destroy the chances. No posterior capsular opacification. So it can be this is very dangerous, highly dangerous, I would say, compared to other, because there is one astigmatism, endothelial loss, and cystoid macular edema. But in the lensectomy, there is the incarceration of the vitreous in the scleral incision, where the sclera was incised. And then surgery hinders if the pupil is constricted. It will be have some effect if the pupil is constricted, and the risk of retinal detachment is higher with the lensectomy. And it is mainly advocated for neonates and infant less than 2 years of age, but not preferred by some surgeons. Some surgeons don't choose it. So surgical available options same: lensectomy, lens aspiration with intraocular lens, and lens aspiration primary posterior capsulotomy and intraocular lens, and then anterior vitrectomy. And these are the fives, fancy names. So lens aspiration with the posterior primary posterior capsulotomy, and then anterior vitrectomy, intraocular lens implantation, and the posterior capsular optic capture, posterior capsular PCOC. We also do that, PCOC. All right. So these are the surgical name. You don't have to know more about them, just know the names, and then advantage and disadvantage, these three only, read that one. So post-operative complications include higher, because they are the child, and they have very higher incidence of complications than in adult. So there are five main post-operative complications in children of cataract surgery. So let's it's very easy. So let's get this done. So posterior capsular opacification, the capsule of the posterior side, like posterior capsule, it will lead to opacification because of its because it is more significant in young children. So why does it affect young children? Because it will lead to its amyogenic stimulus deprivation, amblyopia, and the incidence of opacification is reduced when posterior capsulosis is combined with the vitrectomy, like we already discussed earlier. And then in the secondary membranes, like other kind of membranes may form across the pupil, particularly in the micro-ophthalmic eyes, small eyes, that is associated with or that is also or those secondary membrane that is like associated with the chronic uveitis. So the two kind of membrane, either due to the like secondary move formation in the micro-ophthalmic eyes, and then the other is like associated with the chronic uveitis. The secondary membrane will form across the pupil. And then proliferation of the lens epithelium, after the remnant, like suppose this is the lens, this is the capsule, and inside is the lens. All right, so here inside is the lens. So if we will, like, we have to like incise, like this, and then we have to all emulsify, phaco emulsification, and then the lens is removed, and then we will put an intraocular lens with haptic and optic, yeah, like that. And but what will happen is the lens epithelium, the lens epithelium will proliferate will lead to the opacification, like it will also become encapsulated with the remnant of the anterior and posterior capsule and is referred to as the sommering ring. It is also known as the sommering ring. Let's see its figure. So here is the figure of the sommering ring. We can see this is due to the like proliferation of the and the epithelium, lens epithelium. And then, like, children who had like cataract surgery can develop a glaucoma. That is also of two types, closed angle, because the angle is closed, and then is the secondary, like for from other cause it caused the open angle glaucoma. So we will read glaucoma also in the next video that is coming soon. I will try to make the notes asap, but yeah. So closed angle glaucoma may occur in the immediate post-operative period in the micro-ophthalmic eyes secondary to the pupillary block. So pupil is blocked, that will lead to the glaucoma, closed angle glaucoma, easy. And then in the open angle glaucoma can be due to the due to other secondary causes now, secondary causes, and then may develop years after the initial surgery. It therefore is important to monitor the intraocular pressure. So the child who has gone the cataract surgery, we have to we have to like monitor the intraocular pressure. And then retinal detachment can also occur in children, that is usually late complications. So now let's move on to visual rehabilitation. All right, so this is a very important part. So children above the age of the 2 years, so 2 years or older children can be the visual rehabilitation should be can be corrected by the implantation of the posterior chamber intraocular lens during the surgery. So we do the cataract surgery for visual rehabilitation, so for the age of 2 years or more, implantation of the posterior chamber IOL intraocular lens can be implanted. And then for the children below the age of 2 years should be treated by wearing extended wear contact lens, for both unilateral and bilateral aphakia. So in the children below the age of the 2 years, we remove the cataract and then leave the eyeball like that only, and then we prescribe the children with the extended wear contact lens. And when the children the child gains the 2 years of age on his second birthday, after that we will schedule a surgery and then proceed with the above, implantation of the posterior chamber intraocular lens. So spectacles we usually prefer, and the intraocular lens is increasingly being performed, and appears to be effective in safe in selected cases. So it is also done, but mostly extended wear contact lens is done. And then for the occlusion, for the correction of the amblyopia, occlusion and the atropine penalization is done, essential, and atropine penalization will be done. We will read about this both in amblyopia. So IOL implantation, implanted then IOL during surgery, and the criteria for IOL implantation depends on the child age and whether the cataract is either unilateral and bilateral or bilateral. It is perfectly safe and acceptable to perform primary implantation in a child older than 1 year. Some books say 1 year, some books says 2 years. So that's still a part of the discussion. And the foldable acrylic hydrophobic IOL is the most biocompatible IOL. We put that acrylic hydrophobic intraocular lens. Contact lens, if no contact lens, how, when we do put the contact lens, if no IOL is implanted, contact lens are given as early as possible to prevent the stimulus deprivation, amblyopia. For frequent retinoscopy should be performed to decide the power of the contact lens, and then overcorrection, always the overcorrection of the 2 plus 3 diopter is mandatory. And like contact lenses, either silicone or soft hydrogel, are well tolerated. Spectacles, in some children, bilateral aphakia spectacles are better tolerated than spectacles than contact lens. So some children can tolerate spectacles very easily in bilateral cases. In addition, a secondary strabismus may be manipulated by prismatic effect of the spectacles. Bifocal glasses should be prescribed when the child is about to start the school. All right. So what is the guideline for the choice of the intraocular lens and diopteric power? So if the children is less than 2 years of age, then we have to do the biometry, and we have to we have to undercorrect, undercorrect by 20%, and the usual equal length measurements only. So only if the axial length is 17, then 25 diopter, and 18, then 24, 19, then 23, we have to use like this. And then children between the age of the 2 and 8 years of age, biometry and under corrected by only 20%. So if the child is less than 2 years, 20%, and when the child hits the age of the 2 years, then we have to under correct by only 10%. So prognosis, so visual outcome, does the child get does he like gets cured from the cataract? So it depends on various various factors. So we call that prognosis. So it depends on the type of cataract and the timing of the intervention, when was the surgery done, and whether the quality of life and amblyopia was managed or not. So this will very much depend the prognosis, these factors. So near normal vision can be achieved in unilateral congenital cataract, provided amblyopia management is aggressive. So near normal vision can be achieved in unilateral congenital cataract, but we have to do that aggressive amblyopia management. And binocularity, both the eyes, in congenital cataract, binocularity is usually poor. And aphakic and pseudophakic children should be followed throughout childhood, and preferably throughout the life. So pseudophakia means false lens, and children without any lens from the congenitally, they have to follow out, they have to go for follow-ups, frequent visit to the ophthalmologist clinic. So this is the prognosis. Thanks guys, this was it. I hope this has made you clear, or I don't know, give you some insight about cataract before you actually study or attend any kind of lecture. So yeah, just you have some ideas about the topic. So you have to study it from any kind of book like Parsons or AK Khurana or any kind of other books. And yeah, I hope this was useful. Even if you remember 40% is not even 40, 20% of the things that I said, then you can study at your own, and then you will improve within the time. And posting all your ophthalmology posting, you will learn all the topics. So yeah, if there is any anything you don't understand, then please comment below, or some topics you would like for me to talk about, not teach but talk. As after we discuss more, then the long we discuss, then more it will be on our brains, and it will be more practically useful to you. So yeah, comment down any kind of topic you want to know more. Thank you for watching the video. If you had made this so far, and consider subscribing. Thanks.